So the aims of the webinar today is really, first of all, to introduce the census longitudinal studies and the research support units for each of those studies in the three countries across the UK, but particularly to try and demonstrate the potential of the longitudinal studies for research on health inequalities. So we'll be focusing here on 4 case studies, and we have the authors of each of these research projects who will speak to us about their research. And these range from topics like selective migration and health to an exploration of differential education outcomes for children with disabilities. And each of these studies uses the longitudinal studies in each part of the UK to give a good reflection of the breadth of research that's possible with these data sources. So here's the programme for today. I'll start off. I'm Alan Marshall. I'm going to give an introduction to the longitudinal studies for health research. And then we'll be followed by the 4 papers on different research projects, starting off with Fiona Cox, then Fran Darlington-Pollock, Stefanie Doebler at the University of Liverpool, and then Sebastian Franke. And then we'll finish off with a question and answer session. So this webinar is organised by CALS Hub. CALS stands for the Census and Administrative Data Longitudinal Studies Hub. The role of CALS Hub is really to support and promote and harmonise the use of longitudinal studies across the UK. So we have a website with a selection of online tools, a data dictionary, and a database of research output that uses the longitudinal studies, and also a help desk for use of all of the 3 longitudinal studies in the UK. We produce briefings of research that uses this data, and also have a research blog with features like a recent citation analysis that we did, highlighting the breadth of research that uses these data sets. So we're here really to assist with UK-wide longitudinal use of longitudinal census studies. This is the team. So I'm an associate director of CALS Hub. Fiona Cox is also here, who will be presenting later. She's the CALS Hub project manager, also based with me at St Andrews. And we also have Oliver Duke-Williams here from University College London, who is the CALS Hub director, and will be here for the Q&A session at the end of the webinar. So there are 3 census-based longitudinal studies in the UK. So we have a longitudinal study in England and Wales, in Scotland, and in Northern Ireland. So each of these studies is based on census data. So it includes a sample of participants in the census who are followed up over time. And we have 3 research support units who support the use of these longitudinal studies in each of the 3 countries. So we have Celsius supporting the use of the ONS longitudinal study in England and Wales, for example. So why are the census longitudinal studies a really valuable resource for health research? And I think a key feature of this really is the longitudinal aspect of this. So we have data for the same individuals for multiple points in time. So it's a great way to investigate how the health of individuals changes over time, and perhaps in response to circumstances or events that occurred earlier in the life course. And this type of longitudinal data allows us to do some quite sophisticated things in terms of looking at how health transitions vary across periods and across cohorts, for example. Now, there's lots of different longitudinal sample survey data sets that can be used in the UK, but what is particularly useful about the census longitudinal studies is that they have a relatively large and representative sample size compared to other longitudinal surveys. And one advantage of that is we can analyse health outcomes for groups that are perhaps neglected in other longitudinal studies, so for example, ethnic minority populations. But another nice feature really is that because the census is compulsory, we have really high rates of retention and response in this survey. So issues of non-response, which occur in many other longitudinal sample surveys, are less of an issue in the census longitudinal studies. And while we have information that's quite sparse in terms of censuses being 10 years apart, we also have information on events from other data sets. So vital data on births and deaths, for example, NHS data, school data, and so on. I'll talk more about those later. And work's going on to add indirect estimates of information such as income to the census longitudinal studies. And I include a link here to work by Chris Dibben and Tom Clemens on that. So a key advantage of longitudinal census data is that we have lives linked over time, and we can see how health outcomes evolve over time. So here's an example of a female member of the ONS longitudinal study. That's a longitudinal study in England and Wales, who was 21 in 1991. So we can see this person entered the census in 1991. We have lots of information on events that occurred through this person's life. So when she got married, hospital admissions such as appendicitis. We have information on the births of children. We also have information on emigration and then re-entry to the sample at a later point in time. We have information on health events. So here a hospital admission for myocardial infarction, then to later stage lung cancer, followed finally by death. So we have a great deal of linked data to this core information that we take from the census itself. So an alternative way of thinking about this is through a Lexis diagram. So here on this diagram we have time on the horizontal axis, we have years, and on the vertical axis we have the age of a person. And we can see here that this line here represents the aging of a person who was born in 1950. And this person is in the ONS longitudinal study, so we can see the first time that they were actually recorded in the census, the first time the census was included in that particular longitudinal study was 1971. So every 10 years we have information from the censuses on that person's circumstances and how they evolve over time. But what we also have is the dates at which key events happened in this person's life. So this might be marriage, it might be from birth certificates, for example. But I mentioned this idea of looking at how cohorts differ in terms of how health evolves over time. We can also use longitudinal studies to do this. So we might look at a cohort that was born at a later time point. So here's a cohort born in 1981, or an earlier born cohort here born in 1931. And we might look at quite interesting groups. So we might look at this particular cohort, which relates to somebody who moved into a migrant who moved into England and Wales at the age of sometime between the 1981 and 1991 census, but had a particular birth date, which meant they were included in the longitudinal study sample. So here's a bit more background information on the longitudinal studies in each of the countries across the UK. So we have the ONS longitudinal study in England and Wales, the Scottish longitudinal study, and the Northern Ireland longitudinal study. And you can see some differences between them. So, for example, the sample size varies across these samples, reflecting the different sizes of countries. So in England and Wales, the longitudinal study has a sample size of around 580,000, which is around 1% of the population. Whereas Northern Ireland has a similar sample size, but clearly that comprises a much greater percentage of the population in Northern Ireland, 28%. And the time points that we have this data available to also varies. So the longest running is the ONS longitudinal study, for which we have data from 1971. I've also included in this table a selection of the vital statistics that are included in the different longitudinal studies. And I've talked about some of these already. So the vital statistics give us information on births and deaths, stillbirths and infant deaths, and information on widow or widowerhood. We have information on immigration and emigration from the NHS Central Register. But we also have other information on health, so information on cancer registries, for example. In the Scottish longitudinal study, we have information on education, aspects such as attendance, exclusions, and Fiona will be talking a bit about this data in her presentation. So we're going to be profiling 4 different papers in this webinar that use longitudinal studies in different countries within the UK, but I just wanted to show a couple of other publications that have been quite influential and have used this data set. So here we have work by Tom Clemens and Chris Dibben using the Scottish longitudinal study to try and link neighbourhood characteristics to birth outcomes. Or here, a new and emerging area of research. Here's a paper written by Anna Hansel. And here, the ONS longitudinal study is linked to area data on air pollution. And the aim of that study is to link air pollution to long-term mortality risks. And similar research is going on in Scotland. And finally, a methodological paper here, which is really aimed at making easier the access to longitudinal data. So this is a paper led by Adam Dennett that develops a synthetic longitudinal data set for England and Wales. So here we have work trying to produce open access synthetic longitudinal study data sets, some which cover key core variables such as age, religion and general health. Now these closely resemble the longitudinal studies, but they don't contain any real longitudinal data. And one of the values of this is that it enables researchers to try out their analysis, test hypotheses on a freely available data source before applying to use the real longitudinal study data. And it's also possible to apply now for bespoke synthetic data for the Scottish longitudinal study. So this gives you a synthetic version of the actual data set that you've applied to use to test analysis. So here's the programme for today. I've finished my introduction to longitudinal studies for health researchers now. So I'll now pass on to Fiona Cox from the University of St Andrews. So Fiona Cox is the project manager of the CALLS Hub. She also works as a support officer for the Scottish Longitudinal Studies and is also part of the Deprived HUD's research project led by Martin van Haan. So in her paper today, she's going to explore educational inequalities in educational outcomes for children with disabilities in Scotland. So I'll pass over to Fiona.
Hello everyone. Apologies for having some sound. Hello. Can everyone hear me all right?
Yes, you're back live now. All clear.
Okay. Hello, sorry about that. We're having some technical difficulties here. I'll just bring my slides up. Okay. Okay, there we go. Sorry about that. So today I'm going to talk about an exploration of educational outcomes for children with disabilities. And this is work that I've done on the SLS jointly with Alan. So my research questions: do children with disabilities face educational disadvantage? Specifically, do they tend to leave school earlier? Do they achieve fewer qualifications? In the UK, the prevalence of disability amongst children we don't have an exact measure. It depends on which measure is being used and the definition. So some agencies will use special educational needs, some will use LLTI, which is limiting long-term illness, and others stick to more closely to the Equality Act definition. But the estimates vary between 5 and 18%. Reid et al. Did a very large scoping study and they found 23 different papers which gave an estimate, and it ranged between 5 and 18%. And certainly in Scotland, at the 2001 and 2011 censuses, just under 5% of 0 to 15-year-olds in Scotland had a limiting long-term illness or a disability. So reports and analyses suggest that disabled children are more likely to be disadvantaged. They're more likely to live in poor socioeconomic conditions. They're more likely to live in a single parent family, and they're more likely to have poor educational and employment outcomes. So specifically looking at educational outcomes, the DWP have reported that disabled 19-year-olds are less likely to have an A level than their non-disabled peers. And the Equality Human Rights Commission reported that children with special educational needs are far less likely to achieve 5 good GCSEs. And they've said that the need to close the qualifications gap for disabled people is one of the most significant inequality challenges facing Britain today. While there is some indication that the gap is narrowing, there is still a disadvantage for those with disabilities. So some gaps and issues with previous research. The methods in particular tend to be based on cross-sectional surveys or administrative data. And longitudinal study is extremely rare, but as the World Health Organization pointed out in their World Report on Disability, it's necessary to allow explorations of causality, even to work out whether it's disability at a younger stage in childhood or a later stage in childhood, which is important. You really can't get any sense of causality without doing longitudinal research. So the other issue has been the measures. It's very difficult to measure disability accurately, and as I've mentioned, some different proxies have been used. Special educational has been used by the Department for Education and others, but that includes those with emotional and behavioural support needs as well as disabilities, so it's not really a very close proxy. Limiting long-term illness is the one that's most widely used. However, there has been some research suggesting that that might not capture all types of disability equally well. In particular, more hidden disabilities like mental health tend not to be picked up by LLTI questions. It tends to be more physical disabilities. So the current paper investigates educational outcomes for children with disabilities, adding a longitudinal aspect from 2001 to 2011. And I've exploited the new impairment question in the Scottish 2011 census, which allows a more accurate identification of disability and more fine-grained analysis. So this is the question that was added. Do you have any of the following conditions which have lasted or are expected to last at least 12 months? And then you can see there's a whole different list of categories. There was also a write-in option, and those write-in answers were recoded into the other categories. The Northern Ireland census of 2011 also included a very similar question. Excuse me. The categories aren't identical, but it would certainly be possible to collapse categories to make them comparable. So my research questions then. Are children with disabilities more likely to leave school early? And I've taken that definition as leaving either before they're 16 years old or as soon after as they're allowed. And secondly, how does academic achievement compare for those with and without disabilities? So are children with disabilities less likely to sit higher exams? So for the benefit of those who don't know, the Scottish Highers are roughly equivalent to the A level in England and Northern Ireland. And also, are children with disabilities less likely to achieve 3 good A to C grade passes in their Highers? So my sample were SLS members who were present at both 2001 and 2011, and they were aged 3 to 11 years at 2001. So that gave me just under 24,000 children with a mean age of 7 at the 2001 census. And as you can see, we have quite a good gender split between them. So looking at the full sample, this is the percentage of the full sample who reported having each of those impairment types at 2011. You can see, for example, that learning difficulties is quite high, long-term illness, seizure condition. So it was roughly 23% of the full sample who reported having at least one of these conditions. And I should point out that categories are not mutually exclusive in these. So my derived measures for the analysis, disability, I took to be children who reported having at least one of these conditions in the impairment type question, but who also reported that their day-to-day activities were limited. So that trying to keep it as close as possible to the Equality Act definition. For early leavers, the technical definition for early leavers are those who leave school before they are legally allowed, which in Scotland would be age 16. But I thought it was important to also capture those who leave school as soon as they could. because I thought that might capture some kind of disenfranchisement with the system. So my definition includes those who left before they were 16, but also those who left as soon as they were legally allowed. So we did a series of logistic regression models on these. So the first was with the dependent variable of leaving school early. So the control variables here were gender, deprivation at both time points, household type, so that's the family type, because it's single parent, married parents, etc. Parental disability at 2001, ethnicity, and then all the different health conditions. So the results, focusing on the disability things here, what we have here are the predicted probabilities of leaving school early. And you'll see the orange bar on the graph, that's the baseline. So that's, as you'll see at the bottom, that's people who are male with no disability, least deprived, etc. So compared to the baseline, children with limiting long-term illness at 2001 or 2011 were no less likely to leave school early. And looking at all the different types of health condition, the only one which came out significant was mental health. So children with mental health conditions are significantly more likely to leave school early or as soon as they're allowed. The second model looked at whether children were registered to sit at least one higher exam. So again, the same control variables were entered into the model. So you can see here that this time disability at either time point was significant. So that children with a disability were, it was more likely that they would not be registered to sit any hires. And you can see that's for the health conditions, this was particularly significant for those with learning difficulties and also for those with learning disabilities. The third model was whether children achieved 3 good A to C grade passes in their hires. So again, the same variables were entered. And you can see here this time, overall disability at either time point wasn't significant, but children with learning difficulties were significantly less likely to get 3 good higher passes. So just to summarise then, there was no link between LLTI or overall disability and the probability of leaving school early. The children with LLTI or disability were significantly less likely to register to sit hires than children without health problems. However, the children with the disability were no less likely to achieve 3 good higher passes than their peers. Looking at the individual types of health condition, the children with a mental health condition were significantly more likely to leave school early or as soon as they could. And the children with learning difficulties or learning disabilities had a much lower probability of sitting hires, and those with learning difficulties were less likely to achieve 3 good higher passes. The children with the other specific health condition types didn't appear to be significantly disadvantaged for these outcomes. So just to reflect slightly, the finding that children with disabilities are just as likely to stay on age 16 might indicate that school has a positive supportive role for these children. For example, they have peer groups, they have access to support services, etc. Some have suggested it may be that children stay on due to barriers to progress into further education. However, there's been a lot of reports in the press, particularly last year, about cuts in college courses in Scotland, and it was felt that the types of courses which were being cut could disproportionately affect people with disabilities. But on the positive side of things, the results, the results indicate that children with mental health conditions may require additional support if they're going to be encouraged to stay on at school. Looking at the educational outcomes then, the finding that children with disabilities are less likely to register to sit hires is of concern. And I think it's vital to ensure that children with disabilities are being given the same opportunities and options as other children, that their chances are not being limited by parents or teachers or support workers who just think, no, we won't register them because they can't do it. They have to be given the same chance. And I think it would be valuable to have qualitative research in that area to check, to explore whether that is actually happening. It is, of course, the case that children with learning difficulties and disabilities, by the nature of their condition, have additional barriers which directly impacts academic achievement. And it may be that additional support is needed to help them reach their full potential, if at all possible. And finally, just to give my acknowledgement slide for the SLS, and thank you very much for listening.
Okay, great. Thanks very much, Fiona, for that. So we'll now move to our next presenter. So our next presenter is Fran Darlington-Pollock. Fran is a lecturer in human geography at Queen Mary University, and her previous research at Leeds University is focused on the nature of ethnic inequalities and explanations for changing health gradients linked to factors such as migration, deprivation, and social mobility. So we're really pleased that she can speak today, and today her talk is going to focus on selective migration and its impact on spatial health inequalities.
Thank you, Alan. So as Alan said, today I'm going to talk about the relationships between selective migration, health and deprivation, and how we can explore those using the longitudinal study. So I'll first talk a little bit about what we already know about selective sorting in health and tell you exactly what I mean by.
Fran, sorry to interrupt you. I can't hear you actually. Are you muted on your settings?
No.
No, Fran, if you could just move closer to your microphone and speak up a little bit. I think your mic is probably a little bit too far away from yourself at this point.
Okay, is that better?
A little bit. If you just mind and speak up, everyone should be able to hear you fully.
I can see you fine. It's just the I can't hear you.
I'll try to talk louder. Can you hear me now?
Okay, great. Perhaps it's a problem with me, so you carry on. I think everyone else can hear you, Fran. It's just me.
Okay, all right, great. I'll carry on. So I'll talk a little bit about what selective sorting is and what that means in terms of health, and then talk about the data and methods that I use here. And these are just one or a number of ways in which you can look at these relationships rather than the only ways you can look at them. And the specific things I'll be doing are comparing gradients when you allow movement to occur or when movement does occur with what would happen if people didn't actually move, looking at differences between the extremes of the deprivation gradient, and then also thinking a little bit about those people who move in the middle of the deprivation gradient. So, what do we know? So we know that the population can be sorted into different life circumstances through things like migration or residential mobility. And I should note at this stage that I'm going to use the term migration synonymously with residential mobility. What's of interest to me is any change of address, not necessarily the scale of that change of address. However, it should be internal migration. So I'm only interested in moves within England, not interested in international migration. Analogous literature has looked at the extent to which social mobility also influences health and health gradients. So this work kind of feeds off some of that research. Now we know that migration is selective. It's an inherently selective process. Migrants are very different from their immobile peers, and you can see that in terms of their age, their socioeconomic status, things like education attainment, the kind of jobs they're in, the kind of areas in which they live in, and also by things such as ethnicity, and crucially for this research, by health status. We also hypothesize or think that perhaps the movement of differently healthy groups, so remember that migrants are selected on their health, whether for good health or poor health, so the movement of differently healthy groups between area types or social classes, and that's the analogous literature on social mobility, might then influence the health profile of different area types or social classes. So this is where you start seeing that perhaps you're going to see a change or a different relationship or a different type of health inequality because of migration or perhaps because of social mobility. So what we're interested in, or specifically what I was interested in this research, is can selective sorting contribute to changing health gradients? And if it does, how is it doing that? Is it resulting in a widening gradient, so you're seeing the gradient get steeper? Does it actually just maintain those gradients? Or in fact, is it constraining these gradients? And we ask if it's constraining these gradients because some literature looking at social mobility and health inequalities previously found and even suggested that social mobility should be used as a policy tool to constrain health gradients, to flatten health inequalities. However, there are some problems, not necessarily problems, but the analytical approach employed in that work meant that we were comparing the health of the wrong groups. We were looking at the health of people moving into social classes and comparing that with the health of the people already in those social classes. And that's not really the area we want to be looking at when we're trying to establish whether or not the movement of differently healthy groups will contribute in a negative way, so widening or just maintaining the status quo. So the ONS longitudinal study is one data set within which you can look at selective migration and health, and it's particularly useful because as a longitudinal data set we can look at people's changing health status depending on whether or not they've moved, and we can also look at that for big subsets of the population. So before I get into that in more detail, I will talk a little bit more about the connections between health, deprivation and migration, because these are important contextual components for this research. So first of all, if we think about health and deprivation, we know that health follows a deprivation gradient. People who live in more deprived areas are more likely to have poorer health than people who live in less deprived areas. So we have that gradient going on between health and deprivation, or along deprivation. There's also then a specific relationship between migration and deprivation. People who are more advantaged tend to migrate to or move between less deprived, more attractive locations. Conversely, people who are less advantaged are more likely to drift down into or become trapped in more deprived areas. So you've got this idea that people who are more advantaged are staying in the less deprived areas and probably also having better health, and the inverse being true for people who are less advantaged in more deprived areas and perhaps less healthy or more unhealthy. And then we have a very complicated relationship between migration and health. And there are so many different facets to this, but only a number with which I can kind of play with this data. But first of all, we must note that the majority of migrants tend to be younger. So if you look at the age schedule to migration rates peak in younger ages. And of those younger migrants, they tend to be relatively healthy. They're usually more healthy than their mobile peers. However, people who move in older ages might actually be moving because of their poor health. They might be moving towards formal care. They might be moving towards living closer to a family. So although the majority of migrants are younger and healthier, people who are in poor health may move because of their poor health. But importantly, people who are in poor health may also not be able to move because of their poor health. Another layer of complication is the fact that migrants' health, the health of themselves can be affected by the process of migrating. Moving house across any spatial scale is an incredibly stressful experience, as I'm sure we can all attest to, and it can have implications for health. And then finally, there's the idea of migrants being harbingers of disease, so being able to spread disease. So those are the kind of various layers with which you must think about migration and health. But crucially, we're thinking about what is it about the health status of migrants compared to non-migrants. And when you're thinking about the connection of all these different issues, there are various calculation and variable issues that you have to think about. So it's things like, are there different qualities of data recording within the same data set? So have we got a consistent recording of health over time? Have we got a consistent way of looking at whether or not somebody's a migrant? How are we attaching deprivation? Are we linking different data sources? So those are some of the kind of wider issues that you have to think about when trying to explore these interrelationships. And there's loads of ways of making it more complicated. For example, you could add ethnicity into the mix and say that all of these different processes might be variously attenuated by ethnicity. But for the purposes of this presentation, I'll try and keep it quite simple. So the data that I've used, and Alan already gave a nice introduction to it, but so I was looking at the ONS longitudinal study for England and Wales. I've put in Wales in brackets there because I was only interested in England, and the key variables that I was interested in here are health status and migrant indicators. And so this is whether or not someone's address is different to 10 years previously. So I'm interested in from 1991 to 2011, and my sample reflected people who were either present at 1991 and 2001, or were present at 2001 and 2011. And if we go back a little bit to thinking about what I was saying about international migrants, I wasn't interested in international moves. So anybody who was an international migrant, so has an address outside of England 10 years previously, is excluded from this sample. So the specific variables I was looking at, I thought about health in terms of limiting long-term illness. So this is the presence or absence of limiting long-term illness. And if we go back to the idea of some kind of variable issues, there was a slight change in the way in which health or limiting long-term illness at least was recorded in 2011 compared to 2001 and 1991. But essentially, I'm just interested in whether or not people say they are limited by an illness or they are not limited by an illness. I then define area type, so this is looking at whether or not people are more advantaged or less advantaged in their spatial location using deprivation. And this is a deprivation score that has been attached to the longitudinal data, so this is something that you can do to look at the different quintiles in which people live. So quintile 1 is the least deprived, and then we move down into quintile 5, which is the most deprived. And by identifying these different deprivation quintiles, you can then identify transitions between those quintiles between 1991 and 2001, or 2001 and 2011. So has someone moved into or out of the least deprived area? Has someone moved into or out of the most deprived area? Or has someone just churned within quintile 2, 3, or 4? So my migration indicator, as I said, is a 10-year migration variable. It's comparing address to 10 years previously, and this allows me to identify people who have moved, so movers, and people who have not moved, so stayers. So I'm going to present or briefly talk about 3 different approaches that you can do when thinking about selective migration, deprivation, and health. 3 different approaches that will give you different slices of the same picture. So the first way is to compare gradients. So you want to know what is the health gradient along the deprivation quintiles when people are moving within and between these deprivation quintiles over that 10-year period, compared to what it would be if we'd said, let's put everyone back to where they started. Let's assume that nobody actually moves. Is the gradient different? Do we have a steeper gradient when people move between quintiles than when people don't move? So this is obviously making quite a lot of assumptions about what people would otherwise do in a 10-year period, but it still allows you to look at the kind of impacts that we might expect the movement would be having. So I use standardized illness ratios to look at the health status of these different quintiles and calculate that health measure by their health at the end of the study period, so either 2001 or 2011, and then look at this for population by their destination deprivation quintile and their origin deprivation quintile. So this is for the whole sample. There's no distinction between movers and stayers here. And then you can calculate the ratio between the most deprived and least deprived areas to see whether or not you have a difference with movement or without. If you do see a difference, it's then worth working out or beginning to explore where that difference is going on. And most commonly, this is by looking at transitions at the extremes. So moves into or out of quintile 1, the least deprived areas, or into and out of quintile 5, the most deprived areas. So then you can calculate standardized illness ratios for differently transitioning groups. So this could be on the one hand for movers, because obviously your area type can change because you have moved house. But you can also do this for stayers, because people's area type might change due to changes in the area itself. And then you can have a combined look at seeing what is the overall influence of selective sorting when you look at these transitions. And then finally, the last little bit that I did was saying, okay, we know that transitions at the extremes might be important in affecting health gradients if movement or migration is having an influence. But as the majority of the population live in the middle, so live in quintile 2, quintile 3, quintile 4, what's going on there? And this is something that was generally neglected from a lot of the kind of literature in this area. So I wanted to have a look at it, and I used the slope or relative indices of inequality to look at what happens across the whole spectrum. So this is using these indices of inequality and thinking about it in a similar way to when we compared gradients. So what is the slope or relative index inequality when you allow movement to occur, and this accounts for transitions across the whole deprivation spectrum to what that would have occurred without any movement. So on to some results, and I have tried to keep these quite simple for you. Now, first of all, this is comparing gradients. So we have the darker graph, we have 2 graphs here. One's the 2001-1991 period, and one's the 2001-2011 period. So the darker bars are the health gradient that would occur or did occur because people are moving about. So we're allowing people to move within and between deprivation quintiles alongside those people who don't change address. And you have, and that's the gradient that you can see. The paler bars are what would have happened if we put people back. So the first thing you can see if you look at 1991 to 2001 graph is that down at the bottom, those in the least deprived area, there is better health for people who have moved. If you allow movement to occur, then you would see if people didn't move. And then if we go right to the top, so the most deprived areas, we see that when we're allowing movement to occur, there is poorer health in the most deprived quintiles than what would have happened if we say, let's just put everyone back to where they started. And you get a similar, although slightly kind of shallower picture when you look at the 2001 to 2011 graph. Now, to quantify that, we can work out the rate ratio between the most deprived to least deprived areas. And in both years, although to a slightly different magnitude, you see that when movement is allowed, so when people are allowed to transition between the deprivation quintiles, you have a steeper gradient. So the conclusion to this part of research is that health gradients by deprivation seem to be steeper within and between deprivation quintiles than what occurs when you put the population back into their origin quintile. So movement appears to exaggerate health gradients, but how is it doing that? So that leads us on to the second part where we're looking at transitions. And I'm going to walk you through the transitions specifically for the 2001 to 2011 period. So these are the standardized illness ratios for movers who so this is people who've changed address. Remember that people can change address but remain in the same deprivation quintile, which is why we have stable Q1 and stable Q5. Now, stable Q1 has the best health, stable Q5, which is the most deprived area, has the poorest health. People moving into quintile 1, so that's Q2 to Q4 2001 and then Q1 in 2011, have better health than those who have moved out of quintile 1 in 2001. So people moving into quintile 1 have better health than those people moving out. And then if you move towards the top, so into the more deprived areas, people who move into quintile 5, so the most deprived areas, has poorer health than those people who are moving out. Now this is the sequencing or the patterning to health that we would expect if this movement of the population is going to contribute to widening health gradients. So what happens when we look at stayers? Are we seeing a similar pattern? So this is people whose area type has changed. Now what we see is a slightly different pattern. You see that people who move into quintile 1 actually have slightly, although not significantly, better health than people who have moved out of it, and the inverse for the stable deprivation. Now if we put the two together, you can see some even more interesting patterns, and you see that people who are moving, people who change address, at the bottom, so in the least deprived areas, they have much better health than their stable peers. And this contrasts with people who are moving house and moving in the most deprived areas. They have much poorer health than their stable peers. Now, this patterning to health that we're seeing that happens both in 1991 to 2001 and 2001 to 2011 for movers suggests that this movement of the population can contribute to widening health gradients. What we're seeing is that transitions into and out of Q1 and Q5 by the movers can contribute to widening health gradients in both periods. And importantly, that movers churning within quintile 1 seem to have significantly better health than stayers who remain in quintile 1. And movers churning within quintile 5 have significantly poorer health than stayers who remain in quintile 5. So there's clearly something going on in terms of the movement of the population. Now, last but not least, to go on to the middle, to think about, is this effect just going on at the extremes, or can we actually see something more going on across the whole population? And these graphs here plot the slope index and the relative index, plot the slope index of inequality, and then we have the relative index of inequality down at the bottom for scenarios where people have been put back to their origin deprivation in 2001, contrasting with what happens if you allow the population to move, so the health that occurs if they are allowed to move in 2011. And in both cases, so absolute differences from the slope index of inequality and relative differences from the relative indices of inequality are steeper when movement allows. So it's not just movement at the extremes. When we account for movement across the whole deprivation spectrum, you're seeing that selective sorting through residential mobility or migration is playing a role. The steepening slope seems to be attributable to worsening health for all deprivation quintiles apart from those in quintile 1. So people in quintile 1 see marginal improvements to their health, whereas the steeper slope for everywhere else is because the health of those people got poorer, or the health of that area got poorer when the movement had occurred. Relative differences in health also increase when movement occurs. So this is when you're comparing it to putting the population back into the origin deprivation quintile. So those are just a number of ways in which you can start looking at these relationships and give you a flavour of the kind of things that you can do with the LS in this area. And there is my thanks and credit to the support team and the ONS. Thank you.
That was great, Fran. Thanks very much for that. Okay, so our next speaker is Stefanie Doebler. Steffi has just moved to a research position at the University of Liverpool. She previously worked at Queen's University Belfast, where she was part of the Northern Ireland Longitudinal Study. And we're going to change topic and data set now. So she's going to give a paper on the association between informal caregiving and mental ill health in Northern Ireland.
Can you hear me? Hello?
Absolutely, you're good to go, Steffi.
Great, brilliant. Can you also see my slides? Yes?
Yes, absolutely. All here ready and waiting. If you just hit start slideshow.
Okay, thank you. Okay, thanks for coming. Okay, this paper is on informal caregiving and mental ill health in Northern Ireland, using the Northern Ireland Longitudinal Study. And I've done this paper with my co-authors, Assumpta Ryan, Sally Shortall, and Aline McGuire. So this is based on a paper that we published recently. Okay, I'll say a little bit about the theory and start off with that, and talk about factors that may be influencing the mental health of caregivers, and then I'll just guide you through the data and methods and through some results. I've included two famous paintings by Edvard Munch, The Sick Child and Death Struggle, because it shows you a vivid imagery of the suffering and strain and burden of informal caregivers, as it is often perceived. There is a large literature on effects of informal caregiving on mental health, and the majority find positive links between being a full-time caregiver and having a high caregiving workload and mental ill health. So being a full-time caregiver was found to be related to experiences of strain and stress and burden, in particular caregiver depression has been well researched in numerous studies. Most of them are clinical trials and qualitative studies using interviews or studies using surveys, but something specific to the ONS longitudinal studies and the NEILS are the amazingly large sample sizes, which allow us to look into smaller population strata, comparing across age groups and other traits of population. And some studies did find that informal caregiving can even have beneficial effects on health and mental health, because caregivers may have a sense of being needed in the community, having a task to fulfill. O'Reilly and others found that in many cases caregivers might not necessarily suffer strain and burden. Okay, factors that can affect the mental health of caregivers are gender and age. In lots of studies there were significant relationships. The numbers of hours spent providing care, and the number of persons cared for, and socioeconomic factors such as employment status, income, but also the health condition of the cared for, particular different health conditions like dementia or psychological health conditions or others. Bereavement in combination with caregiving was found by Moriarty and others in a recent study to be related to for mental health, and support networks, and also the policy context, whether there's respite care, whether caregivers are actually informed about policies that might help them, also are strongly related to their sense of well-being and mental health. Using the Northern Ireland longitudinal study to examine the mental health of caregivers in Northern Ireland, I cut this slide a little bit short because Alan has already introduced all the longitudinal studies, just to highlight the exceptionally large sample size of more than 500,000 individuals in the NEILs. Which is really amazing data to do this kind of research. And there are linkage possibilities to administrative health and social care data that are specific to Northern Ireland, and I can say a little bit more about that at the end. Our data linkage studies linked two data sources, the Northern Ireland longitudinal study, and we used a subsample of the population aged 16 years and older, which gives us a sample size of 378,365 individuals who had a link to both the 2001 and 2011 censuses. And we wanted an adult population, so we chose 16 years and older. And we linked to this antidepressants prescription records. The British National Formulary has categories for all medications that are existent in the UK, and it would be category 4.3 antidepressants. And these data come from GP practices from the Northern Ireland Enhanced Prescribing Database, which is available through the Business Services Organization and the Honest Broker Service, and is then held within NILS RSU, the research support office of the longitudinal study, where the data can be requested, required, and then used. And we linked more than 1 million prescription records from 2010 to 2012 to the NILS. It's worth mentioning that there is also other possibilities. There are data on antibiotics, anti-diabetics, cancer treatments even. So it is really worth giving them a ring and see if the data you might be interested is available. In our particular study, we used from the census questionnaire the question on caregiving. Do you look after or give any help or support to family members, friends, neighbors, or others because of either long-term physical or mental ill health, disability, or B, problems related to old age? And there are 3 categories of caregiving workload: 1 to 19 hours a week, 20 to 49 hours, or 50 hours or more per week. Now, this is a limitation of this study. These are quite broad categories, but those are the categories that are asked in the census, so we have to live with this limitation. Mental health was also asked in the census, and Fiona showed you a slide with very similar questions to the one in Northern Ireland as well. So there was a question on, do you have any of the following conditions which have lasted or are expected to last at least 12 months, an emotional, psychological, or mental health condition. And our objective mental ill health measure, so that this census question was subjective mental ill health, and objective mental ill health is whether the respondent had been prescribed antidepressant between 2010 and 2012. And our method of analysis is also binary logistic multi-level modeling, with respondents nested within super output areas in Northern Ireland. So these are small area geographies, so that we could also look at the level of remoteness of the area someone lives in. And I'll show some results. So in our sample, 15% of the respondents are caregivers, are informal caregivers, and it's 56,393 persons. 70% of them are female caregivers, and if we look at the hours spent caregiving, the majority spent between 1 and 19 hours per week, and that's 56%, but quite large groups, 16% spend 20 to 49 hours per week delivering informal care, and 27% 50 plus hours. And we looked at the age distribution, and the vast majority is in the middle age cohorts, 35, but then 40, 50 to 65 age cohorts, and only 17% are young caregivers aged 34 or younger. So these are just some bar charts on frequency distributions of reporting mental ill health in the census, on the census questionnaire, and being prescribed antidepressants. And first of all, we see three things. First of all, Northern Ireland is a special case. Even among those who don't deliver care, 21% of the population have been prescribed antidepressants, which is specific to the particular history of the Northern Ireland conflict. What we also see is that mental ill health is underreported on the census questionnaire. So a lot more people have been prescribed antidepressant by their GP than actually report having a mental health condition on the census questionnaire, which isn't a big surprise because these are sensitive items and there is still stigma attached to mental ill health and talking about mental ill health. So we've done some binary logistic. What I also wanted to say is that if we look across hours spent caregiving, then those who spent 1 to 19 hours are actually slightly, albeit non-statistically significantly, but slightly less likely to be prescribed antidepressants, whereas those who care for 20 hours plus or even 50 hours plus are considerably more likely than non-caregivers to be prescribed antidepressants, but also to mention having a mental health condition on the questionnaire. And we're moving now on to the binary logistic multi-level models that we've done on mental ill health and antidepressants. For the census measure, we found only that those who care for 50 hours plus are more likely than non-caregivers to report a mental ill health condition. But if we look at prescription data at the likelihood of being prescribed an antidepressant, then those delivering care for 20 to 49 hours and those delivering care for 50 hours plus are considerably more likely to be prescribed an antidepressant. So if we would, these are coefficients from a logit model, if we translate them into odds ratios, then those who deliver 20 to 49 hours would be 10% more likely, and those who deliver 50 hours plus are 23% more likely than non-caregivers to be prescribed antidepressants. And these models control for the household size, age, sex, employment status, and some measures of deprivation as well. Then we've carried out interaction models, looked at interaction effects. These are the marginal effects or the predicted probabilities of each category of caregiving of being prescribed antidepressants by gender. So we found that this is highly gendered. Number one, across the population, being prescribed antidepressants is always very gendered, but also among caregivers. So this compares male and female caregivers, and you see that there is a strong difference between workload of caregiving and being prescribed antidepressants for women, but not for men. At least it's only very slightly significantly the 50 plus hours care category for men. So this is really interesting with regards to gender. We also looked at age and employment status, and with regards to age, we found it's predominantly the younger caregivers aged 16 to below 40 years of age, or below 50 years of age, sorry, who are more likely to be, if they are full-time caregivers, to be prescribed antidepressants than other people, than those who are not full-time caregivers. And it doesn't affect so much the older caregiver population statistically, which is also interesting. We looked at employment status and found that those who are in full-time employment are better off than those who are not in employment or part-time employed across caregiving workloads. And no, we have to say that those not in employment includes retirees. So there is a retirement and age effect there as well. But we find that across groups of those in full-time employment are better off, and also for the group of part-time employed people, that the gap between those who have a high caregiving workload or a low caregiving workload or are not caregivers is considerably higher than for the other groups. So there seems to be an effect of giving up employment. Now, this is quite a noisy graph, and I'll just quickly highlight a few results from this. We've looked at caregiving transitions from 2001 to 2011 and employment transition 2001 to 2011. However, there are some caveats. We don't know really what happened between the two census points. These are 10-year intervals. But what we see, even considering that there will be a lot of noise in the data because of this limitation, those who have been in full-time employment at both time points are considerably better off with regards to not being in need of antidepressants, and those who have been caregivers at both time points and those who give up work in order to be a caregiver are worse off. And we looked at area level effects as well. Proximity to services is an index measure that's supplied by NISRA, the Northern Ireland Statistics Agency, and it basically measures living in areas that are remote, that are far away from services. So how close in terms of travel hours, or travel time by car, how close am I based to GP practices, shops, and other amenities. And we find that those with a high caregiving workload, the light blue and light purple lines, they are the more remotely they live, the further away from services, the higher the slope, the more likely are they to be prescribed antidepressants. But those with a lower workload or non-caregivers aren't, which we found really interesting. So how do we try to interpret our findings? So we find positive relationships between the number of hours spent caregiving and both indicators of mental ill health. We found that long-term caregivers, but there is a caveat, we don't really know what happened between these two censuses, but if we assume they are long-term caregivers, those who have been caregivers at both time points and those who deliver more than 20 plus hours of informal care are at a considerably higher risk of mental ill health on both measures that we used. Deprivation and education matters as well as employment and area remoteness. So we found that there may be an effect of social and spatial isolation of full-time caregivers or of caregivers who have a workload of 20 hours plus. That appears to be affecting their mental health. So it might not be so much about burden and about the workload as such, than the problems with regards to mental ill health seems to be strongly related to being isolated, to being far away from services and amenities, to not being in employment. If I'm in employment, then I have more interactions with colleagues, with friends. I'm more involved in life outside the caregiving role. So maybe there is a problem of caregivers being isolated in their caregiving role, which would concur with some of the other literature. Ryan and others presented some finding on this. We need to keep in mind that Northern Ireland is a special case, so the general likelihood of being prescribed antidepressants is considerably higher than in other parts of the UK and indeed Europe. There are some limitations. There might be some self-selection. We don't know about self-selection into the caregiver role. We have no, well, a census questionnaire doesn't supply questions on whether the caregiving role was taken up by choice or not. And we also don't know whether the person cared for is a family member or a neighbor. But what we could do is look at the household composition and look at multimorbidity within the households. And there are some colleagues of mine in Northern Ireland who look at that, who look at the multimorbidity within the households and how that is related to caregiver mental health. So future studies could disentangle these effects a little bit further. And there are lots of possibilities to do future research with these data. The BSO has also other mental health prescriptions other than antidepressants, so it's worth giving them a ring. And one could look at newborns and children in the household, so we could look at age groups of maybe different people who might require care. And the NILS also contains death records, and so does the NIMS, the Northern Ireland Mortality Study. So there is also other data within NILS RSU that can be linked to mental health prescription data, which makes it a really uniquely excellent source for this kind of research. Last but not least, I'd like to acknowledge NILS RSU, the Northern Ireland Research Support Unit. I'm really grateful for all their help they have given us. And the NILS is funded by the HSC R&D Division and NISRA. So without this funding, it would, and the ESRC, of course, and without all their funding, it wouldn't be possible to carry out this research. On the last slide, and we will circulate the slides after the webinar, I've put the websites and phone numbers of the data suppliers for you, so that you can also make some further inquirements. Okay, thank you very much.
Great. Thanks very much, Steffi. That was a really interesting presentation, and a really important presentation, I think, in the context of populations that are becoming increasingly elderly in structure and likely to have an increased prevalence of informal caring. Okay, so our next presentation is from Sebastian Franke, also at the University of Liverpool. Sebastian is a PhD student working with Hill Kulu and David Lucy. His research interests are in health and mortality inequalities, but also methodologically in survival analysis. But he's also interested in population ageing, biodemography, and historical demography. And today his paper is going to look at inequalities in overall and cause-specific mortality according to partnership status in England and Wales. So I'll pass over to you, Sebastian.
Hello. Today I present. Can everybody hear me? Right. Yes. So,
yes, we can hear you fine, Sebastian.
Okay. Today I present the results of two papers that are part of a PhD study I'm conducting at the University of Liverpool, and these are two papers I'm writing together with Professor Hill Kulu, and we're using the ONS longitudinal study to basically look at the ultimate health outcome, which is death. I first will tell a little bit about the motivation for these two papers, about the ONS variables I used, the methods. Then I will quickly show the results of those two papers. The first, which is soon to be published in the European Journal for Population Studies, and the second, which is currently in preparation, and will then end with some possible further steps. So what's background for this study? Married people usually have lower mortality rates than married people. Researchers show this already since quite some time now, and those mortality differences still persist even if we control for education, ethnicity, etc. And usually the men are the ones that profit the most from a marriage or from a partnership. But also, we know that in the last 50 years, Britain, together with other Western countries, has changed. We got low mortality rates, increase in cohabitation, increase in life expectancy, and also a general change in values, which is usually or sometimes referred to as the second demographic transition. And we have also a lot of new household forms that are building up, also increase in lone parent families, etc. So we were thinking, do those mortality differences still exist now that marriage kind of seems to lose its significance. How does cohabitation fit into the picture? And if you find those mortality differences by marital or partnership status, are they due to one specific cause, or can we see them across different causes of death? So we use the ONS longitudinal study, specifically the data from the 2001 census, as well as yearly death events until the 2011 census. We decided for the age groups, for the ages 30 to 85, which is about 330,000 individuals, and marital status or partnership status being our main variable of interest. We control for country of birth, ethnicity, household size, children, education, and socioeconomic status, for which we use the variable, the National Statistics SEC 2001. And further, we also use the household position variable, not as a control variable, but to construct our partnership status variable, to which I will come in a moment. As methods, we use the survivor analysis. So for the overall mortality differences, we use the normal Cox proportional hazard model. And for the cause-specific analysis, we use the competing risk approach, also which uses a Cox proportional hazard model, but here we use the approach proposed by Putter et al., which says that we leave the baseline hazard as well as the control covariates cause independent. So after we did some sensitivity analysis regarding migrants, migrants that were dropouts, we conducted the analysis, we did a mortality analysis by partnership status, and we did this for men and women separately, and the 3 different age groups you can see here, and we got what you can see are the relative risk, with the married being the reference group represented by the red line, and for all 3 age groups we can see that the non-married individuals have indeed a higher mortality rate than married individuals. So in the next step we conducted, we formed our partnership status variable, for which we used the household composition variable, and took the single never married group and split them into singles that are not cohabiting and premarital cohabitants, and we took the divorced and widowed and also split them into not cohabiting and post-marital cohabitants. And so we did the same analysis, and with the partnership status now instead of the marital status. And what we can see here for men, the first 3 graphs are the ones from the previous analysis. We can see this, that the risk for singles, divorced and widowed, especially for men, drastically increase once we exclude those who are cohabiting. These are the results for the other 2 age groups, and what we can basically see from here is that the postmarital group, the fact that the postmarital group, which is always the last bar in each picture, is always lower than the risk for the divorced and widowed, shows that there's some kind of a protection effect given by a partnership status, and the fact that the premarital cohabitants for the youngest age groups are kind of show a lower or similar risk than the married group, show that there's sort of a health selection into the partnerships status. For the course-specific analysis, we used 7 courses. We tried more, but then the events get, we don't have enough deaths for the survival analysis, so we used 7 courses, and the approach we used, computing risk approach we used, basically shows us the contribution of each course to the overall mortality. So what we can see here is that circulatory disease and cancer are the 2 leading causes, which we also know from the normal mortality stats. But what we also now, we can compare the singles, for example, from cancer. We see that they have more or less the same risk than singles dying due to an accident or other causes. If we look at the same for women, we can see that basically the circulatory disease risk is not as high as for men, which means all the other causes contribute more to the overall mortality, and especially here, the cancer being the most prominent, most prevalent cause. If you go to the other age groups, we found that the marital advantage exists for all causes except for cancer. The mortality differences are greatest for the age groups 50 to 65. So that was both for the overall cause and the cause-specific mortality the case, with the exception for mental diseases, alcohol diseases, and accidents, which decline with constant age. And we also found for the cause-specific analysis that cohabiting reduces the mortality risk, especially at younger ages. Although this was probably due to the fact that at older ages, he still does need cohabitants, so extracting the other cohabitants doesn't really make a difference. To summarize the results, as I said, the marital advantage still exists, except for cancer if it's seen as one group. So if you split it into several cancers, for one or the other, we might find a marital advantage. The results, the young ages confirm the acceptable behavior. Here, I probably have to add that other research has shown that the more accepted cohabitation is within the country, the smaller the difference, mortality difference between, or health difference between cohabitants and married couples is. And as we saw, for the youngest age groups, this is seems to be the case. But it also means that if we ignore cohabitants and just look at marital status, we would underestimate the mortality differences for non-married individuals. Possible further steps, including the ONS, could be to link this with the partnership histories from the previous censuses, to maybe go into more detailed cause of death analysis, but this would mean that we would have to probably more aggregate our control variables, and also maybe another thing would be to compare the trends we got with those starting from 2001 or from the 1991 sample. That's the conclusion. And thank you.
Okay, great. Thank you very much for that, Sebastian. That was really interesting talk, making full use of the ONS data on marital status, but also bringing all the mortality data in too. So that concludes all of our 4 research papers. We do have some time for questions now, so you can send those questions in via the chat option. So if you do have a question on any one of those 4 papers or on the longitudinal data more generally, do send them in and we'll answer those. So I've got a couple of questions that have come in while we've been talking. So one of them was about, well, they're both to do with actually accessing the longitudinal data. The first was how long does it take to get the data? So a kind of rule of thumb really is that this would take 6 weeks to access the. There will be more time if you were also asking for the census longitudinal data to be attached to administrative data. So that will be on top of the kind of rough rule of thumb, 6 to 8 weeks. And then another question was on where you go to access the data. So clearly this is very sensitive data, so there's risk of people being identified. So the data is actually accessed in safe settings. And those safe settings depend on the particular longitudinal study. So for the ONS longitudinal study, they're in London and Titchfield, Edinburgh for the Scottish longitudinal study, and Belfast for the Northern Ireland longitudinal study. So I'm just going to check to see if there are any other questions that have come in. I can't see any at the moment, so if any questions do occur, do email them to us. There are just 2 other things that I wanted to say before we finish the talk. Is that the webinar will be being recorded. It will be up online, so you'll be able to watch that again if you want to go over any of the talks at a later stage. But the second one, we'll also be adding a guide to using detail on longitudinal studies as a resource for webinar there. Thanks very much for attending. Final one last reminder before we finish is that we'll be doing a similar webinar to this on the theme of migration also in 2017. Oh, one question has just come in. So the question is, within England, are we able to link the census data to health data or GP data? So I'm afraid that's not possible at the moment. I believe there is data on cancer registrations in England. So the one development with the ONS longitudinal study that is taking place at the moment is researchers are looking to link that data to information on the physical infrastructure within areas. So that might, for example, be include information on the kinds of food on offer in local shops within particular areas and the distance between where people live and different types of food outlets. So that's one development that is occurring, but at the moment, no, it's not possible to get that particular linkage in England. Okay, so I'll finish there. Thanks very much for attending the webinar.